So welcome everyone. It's wonderful to have everyone here just before on the eve of the Thanksgiving holiday. We give thanks for our asthma community joining here in person and also via the web, via webcasting. The technology is such, if you're following us on the web, that you'll need to text the number that's on the screen. So please jot it down if there are questions at the end of our lecture today. 617-759-2424. Chris Fanta sends his regards from afar, and I think he'll probably be webcasting in. Let's hope so, at least. So we're delighted today to have Jayme Dowdall, who's a core member of our lung center here at the Brigham, and she has a deep interest in voice and voice health, and helps to lead the voice program. It's one of the core faculty here in the Department of Otology and Laryngology. She's a member of the Lung Center and really runs a fantastic voice program. Today, the topic is one of those topics that, as a pulmonologist, and I'm sure this is the same for the allergists in the community, we all fear and don't know how to deal with, which is this great asthma mimic, paradoxical vocal fold movement. So we're really happy, Jayme, that you're here today to enlighten us and tell us what to do. So without further ado.
Thank you so much. Thanks very much. It's great to be here. It's actually really humbling to stand before you. Really respect you as clinicians and also as scientists. And this is going to be a fairly data sparse talk compared to probably what you're more used to. So with your permission, I'd like to begin. So we'll go over a little bit, just a refresher on some of the laryngeal mechanics. Our care philosophy, really kind of discuss a little bit more about the differential diagnosis and some modeling for how we sort of think of these types of conditions. Review our current understanding of our assessments. We'll do a little bit on treatments, and my major call to you all is really to think about the ways that we can collaborate in terms of future directions in a non-siloed fashion. That's really what excites me so much about being in this room today. So the take-home messages for our time together really be that this sort of area of investigation is really complex. And that if you're referring for an evaluation, it's best to sort of say, listen, I think that there's maybe something going on in the upper airway that could be contributing to this without putting a specific word or set of words. I hope I'll make my argument for why that's the case. In fact, the title of the talk is now outdated, and it's only been a few months. The last piece is that we have so much yet to learn from our patients, right? So I would just assume that it's probably not in their heads. Maybe our testing or the environment in which the test is performed may not have a relationship to what they're doing on the outside, or on the outside when they're rowing on the Charles, when it's freezing. You know, maybe we're not there. And so our tests are sort of only as good as the questions that we're asking, which is an exciting opportunity, I find. So just a little bit about the unified airway and sort of just a tiny story about my journey into this and why I'm interested. So, you know, in embryology, right, you know, you have the esophagus and you have the airways, and like all of this is cut off, right, because it's the chapter on, you know, foregut development, right? So when we're sort of learning in medical school, it already starts to be siloed. You know, there's a lung chapter, and even within otolaryngology, it's ears, nose, and throat. So we learn about the throat, we learn about the nose, we learn about the ears. I had the fortune of having Jack Krause as a mentor to me in residency. So he's a rhinologist who is also probably a wannabe closet pulmonologist and allergist as well, who really wants to understand the unified airway. And so he kind of really instilled in me that it's important to look at the whole tract. And as a singer and coming into medicine through singing, that made a lot of intuitive sense to me, right? So there's a lot of things that my singing teachers told me about the whole tract that just weren't in the textbook or weren't explained in an integrated fashion, but rather a siloed fashion. So I just encourage us that there's probably a lot of opportunity even from reading each other's literature to the way that we sort of discuss things, to think, well, what happens 5 millimeters above that or 5 millimeters below that? So when I was in my first 3 years of practice, I spent half of my time in a pulmonology basic science lab at Mass General. Jay, Rajagopal, I will be forever grateful to you if you are watching. Really, so the cells are very similar. They're also different, right? So what defines on a cellular basis where you are? How do the cells know where they are? How do our responses change based on location or being able to sense things? So I really just want to think about the unified airway. And you'll see even in some of the literature that we review, like the nose is pretty much the thing that's now left out. So we're now trying to integrate the lungs and the larynx, but there's still a lot of stuff that the air has to get through between the outside world and even the larynx, okay? As much as I love singing, it turns out that's really not the basic function of the larynx. It's really a valve, right? So if we think about the whole point is that the larynx is supposed to let air in and keep bad things out, right? So when you swallow, it's supposed to be a separate system than when you breathe. And if you think about the fact that you can read a book, have a conversation, and eat at the same time, and people do that all the time. So if you're just at ABP, you just watch people eat and talk and walk and drink. I mean, they're walking, drinking, and breathing, and they're not aspirating. It's an incredible system, and it's really dynamic, right? So our regular basic functions, even when we're not exercising, you know, we're multitasking. When we're listening, sometimes we hold our breath because we're concentrating. We'll kind of take a sip of water, listen again. I mean, all this stuff is really complex, but it's happening on autopilot. The way that we learn anatomy, again, is fairly siloed, right? So we look at static pictures, and we think of the larynx moving kind of from side to side. So the vocal folds are opening, and they're closing. But really, they're going up and out and down and together. And really, if you're exerting yourself, and you'll see the larynx moves up and down. So I don't know if you've seen a laryngoscopy right before someone's intubated, but now the residents can send that little snippet on their phone to me at home, being ready to come in, and you can see the larynx open and moving up and down. If you've ever tried to perform a laryngeal procedure on someone who's breathing hard, you have a sense for how much the larynx moves up and down when you're breathing. So it's a very dynamic system. So the way that we learn laryngeal anatomy doesn't quite account for how dynamic the system is and really how much yet we have to learn. I just wanted to put this here because it really kind of illustrates swallowing. So you'll see on some of the laryngeal visits that I show you that food and water go around the larynx and into the esophagus. And the larynx has this really kind of protected space between the epiglottis and the aryepiglottic fold. So the larynx goes up when you swallow, and it goes up to meet the epiglottis. And you'll see kind of a more of a 3D picture for how food and water will go around the larynx when swallowing. I bring that up also just because of the association for some of the laryngeal irritants with reflux. So just to get you used to the anatomy again, we do not need sound for this. In fact, if we could stay muted, that would be great. This is my nose. I had a turbinate reduction surgery, so that's me. So the nasopharynx, the eustachian tubes there, this is the nasopharynx, a little bit of residual adenoid pad, fossa rasa Mueller. You'll see the base of tongue here. So lingual tonsils, vallecula, epiglottis. And what we really want to try to do is correlate what we're feeling on the outside of the neck with what's inside. So if you all hum a little bit, kind of feel emotion. So the Adam's apple is where the vocal folds are within, okay? So you'll see that some of the men in the audience felt down here and the women felt up here. So the gender-based anatomical differences are actually really striking. Right? Women have a lot of extra thoracic trachea, men do not. And old men have very little at all. In fact, the larynx is often just right above the sternal notch. Just an exam on an elderly patient, and I mean, it's striking. So even across the lifespan, the anatomical differences are there. Which, if you think about the onset of some of these different sort of breathing conditions, right, there's a lifespan arc to some of the ages of onset. So could it be anatomy? Could it be hormones? So you'll see on the inside, this is where the inner part of the epiglottis is. So it's above the thyroid notch when you're feeling on the outside. So this is the epiglottis from the side. And then this is the part that you can feel of the Adam's apple. The vocal folds are actually within this. So this is the cricoid cartilage here. So you can actually put needles in here and really tell where you're coming. So when we do office-based laryngeal procedures, we can feel where we're going to poke on the outside and then direct the needle on the inside. So you're going to see my left vocal fold and my right vocal fold right here. So left vocal fold, my right vocal fold. This is the front, this is the back. Patients actually ask what these things are all the time. And they said, well, what's that? I said, well, really, we're looking here. So this is, again, that bag of a sort of an area that's protected when swallowing. So food and water are going to go around here. Here's the piriform sinus. They're going to go into the esophagus. So this entire area should be protected. The epiglottis is up here when we swallow. And then you need the cartilages that we all wanted to ignore during medical school to make this fence. Right, so you have a comma-shaped cartilage, the cuneiform cartilage. So you can see part of it here. If you imagine kind of almost a semicolon, actually, like this, it gives a little bit of rigidity to that fence between food and water going down in there, and then the corniculate cartilages, which are back here. So most people say, oh, those are the arytenoids, and they're on top of the arytenoids, but the vocal process, the arytenoid, is actually down here. Right, so I learned in residency that these were the arytenoids. So it's not until my laryngology fellowship we started operating on them. It's like actually that little diagram with the cartilages that I tried to ignore in medical school actually has something there. So you're going to see the vocal folds abduct or open, and then adduct or close, and then. So that's why. Pardon me. That's why a sniff task is really helpful in that regard.
Stop it.
So I don't. So stroboscopy is another way of us to have the illusion of the biomechanics. So our retina isn't fast enough to pick up how fast the vocal folds move. So we use a strobe light to have the illusion that we're looking at vocal fold vibration. It allows us to figure out if the vocal folds are stiff or vibrating together or separately. So that's kind of just a little bit of an overview of what we look on the exam, and I'll show you some variety of different things. So I'll switch gears a bit to talk about kind of the care philosophy. So I made a request to try to not label the symptoms with a condition or even maybe a label. So if patients Google vocal cord dysfunction, they'll find some things that may or may not be true about their symptoms or who they are as a person. And a lot of what is available on the internet right now is actually I would say poor content, but it's also poor content reflective of our best efforts. Even in the last sort of few years, there's been a lot more sort of naming or unnaming or lumping or splitting of sort of variety of different upper airway conditions. And so if you have a sort of a symptom complex that was known as, factitious asthma or hysterical stridor, patients may find that they don't identify that they're particularly stressed or the stress caused it. So they start to form some conclusions about themselves that may not be valid and may sort of stand in the way of sort of really understanding what their symptoms are, as opposed to who they are or who they identify with. So you'll see in the last 2 years even, there's sort of not a consensus on what things should be called. And maybe if things happen during exercise, maybe they're exercise-inducible laryngeal obstruction or induced inspiratory symptoms, or maybe they don't have to happen during exercise at all. So maybe they're an episodic laryngeal breathing disorder. So that's now maybe one of the functions that covers sort of all of things. But vocal cord dysfunction, I think if you look at some of the stuff, if you Google Patients may not identify with that view of themselves or assume that you maybe mean something about them that you didn't discuss in the visit. So just in talking a little bit about kind of the map of how we think of these types of conditions, that thinking about these as just vocal fold dysfunction or vocal cord dysfunction kind of may hamper the science and the patient management. If we think about sort of the siloed way that we sort of come to these things. And most of the causes are probably not understood. We understand triggers, but maybe not mechanism, or the whole story for the mechanism. And I would also say that maybe there's a simplistic view that symptoms only occur during exertion. I think we're sort of biased to exertional symptoms, and what we see so much in the office is the non-exertional symptoms. But they may not be clear to you, so I hope that will become more clear. So what happens if someone comes into the office? I really am so honored to collaborate with so many of you. And because the larynx is at the intersection of so many things anatomically, we have the benefit of collaborating with so many people. So I find that really enriches our practice, and just want to say thanks while we have the moment. So when people come in, what do they expect? So we do ask them to complete some questionnaires about their voice. Their voice may not bother them, but it's also a window into coordination of breathing. So we're not going to make them do anything about their voice if it doesn't bother them, but it helps us understand what their dysfunction is when they're at rest or with regular daily activities. We have 2 sets of eyes and 2 sets of ears. So this is important to us. We have a physician and a speech pathologist in every visit. Why? Because we're looking at different things. And often when you're performing a procedure, even if it's recorded, having someone else look at the patient instead of the end of the camera gives you information. Oh, are their shoulders up? Are they like this during the laryngoscopy? What about the patient positioning or patient experience may impact your testing, right? And then the patient leaves with a treatment plan or a diagnostic plan that's multidisciplinary the same day. So now we'll move on to some discussion of sort of the differential diagnosis and some models of how we think of this group of symptoms. The main reason for a laryngoscopy prior to treatment is to just rule out something that may not show up on the pulmonary function testing, but may be a different type of variable extrathoracic obstruction, right? So it's really important to make sure that you know what it isn't on some level, right? And so that's how we can be really helpful with the laryngoscopy. Actually, on my board exam, there was a flow volume loop like this, and they asked which condition, was this associated with. So I think the mind map, like what phenomenon may occur during spirometry that may be associated with some other dynamic condition when a patient isn't or is symptomatic. I mean, we're really sort of linking something that's causal, which may not be, but it's made it to the boards. So we have a lot of maybe unpackaging to do. We think of laryngeal breathing disorders or upper airway breathing disorders along a continuum. It's interesting for me to, this chart is from a chapter that we did in 2015, and we sort of think of laryngospasm as the most severe closure of a larynx, right? Closes, stays closed for a while, and something had to really irritate someone in order for that to happen. Maybe it was intubation, horrible reflux episode, but sort of the end point. What's not been focused on until recently is really the throat clearing and cough as a laryngeal irritant or an upper airway irritant, right? So we pay a lot of attention to throat clearing and cough. And then we think of vocal cord dysfunction or paradoxical vocal fold motion as maybe some kind of a laryngeal motion, right, where the larynx is shutting when it's supposed to be open. But it's not quite like laryngospasm, which is a more static closure. So I'll show you why it's actually hard to look at this on laryngoscopy. You have to hear what the person is doing and you have to see them to really kind of make the correlation. The recordings aren't sufficient. So for example, if I'm exercising and then I swallow, my larynx is going to close when I swallow. And if I don't know that the person's swallowing on the test, it's not entirely clear that that's what's happening until the end of the swallow. So that's a physiologic airway closure that you would have, right? So it's kind of an extreme example, but sometimes you just, if you're on a bike and you're trying to go uphill, you're putting more power in. So how we sort of lift or power ourselves is to kind of grunt, right? So sometimes we do it when we are going uphill. So if the power changes all of a sudden on the bike and we're looking at someone's larynx, those types of things kind of need to be in this. So it's not quite easy sometimes. Laryngospasm is more clear on laryngoscopy to sort of see. So how we think of these things has really changed in the last couple of years, actually. So we can think of this sort of as a march where you have a trigger. It may change your breathing pattern. Your posture may change because of it. You may have some change in your voice that may not bother you. You may start throat clearing more often. You may notice coughing. Some of these may or may not bother you. Maybe react more vigorously to sort of any irritation. So maybe you have the same amount of reflux that you had a year ago and now it bothers you, but maybe it's the same amount. So the testing may not be different. And then all of a sudden, you have throat tightness and throat closing of some kind, right? Or do we think of this as sort of a predisposition that you may have from a airway reactivity or allergic phenotype? Same thing. Or do we think of this positionally when you're at rest or exercise or upright or supine or awake or asleep? How many patients have you seen that they wake up with throat closing in the middle of the night? Right? That's maybe a different phenotype, but just as alarming and maybe just as severe, and may relate to daytime symptoms as well that are different. One thing clinically that I think we're all on the same page is that there's a cycle at some point that starts to reinforce itself. So maybe whatever it is that caused it is either no longer to play or maybe one of 10 factors. This is the hardest part of the patient journey. So a lot of the times the patients have seen multiple people. It's taken 5 years or so to get to the diagnosis or differential diagnosis of an upper airway problem. And they really want to know, like, why them, and what is this, and what do I have? So when you're coming from a place of, I believe you, I'm sure that you have something, we need to figure this out. Well, what caused it? So they're either concerned with the cause or concerned with the diagnosis. And often we don't have that answer. The nice thing is, a lot of the times it doesn't matter clinically, so we can help them. But the journey is really an important one. The nice thing is I'm going to give you papers that are all in 2017, so there'll be a list of 5 curated papers for you all today that sort of review the current understanding of where we're at for questions that are going to be outside the scope of our talk. This is a really great paper, the episodic laryngeal breathing disorders. This is sort of the theoretical framework. So one of the ways, again, of starting from your larynx is irritated, here are all the triggers that can irritate your larynx and your lower airways, right? These are very common triggers: cold, odors, allergens, smoke. So what irritates one part of the airway irritates another part of the airway. There may or may not be laryngoscopic findings, and there may or may not be other associated symptoms. So laryngospasm, or difficulty breathing in some way, or they may have coughing, irritation. So whether it's a feeling of irritation or a feeling of irritation and dyspnea, maybe that's along the line of a continuum. So one model. Another model is sort of like if it happens in exercise, it's sort of one of these things, and if it doesn't happen during exercise, it's sort of something else, right? So the sort of split on exercise symptoms and non-exercised symptoms. And then if it's noisy breathing that causes dyspnea, sort of one symptom is just noisy breathing. Maybe it's something else. So really kind of splitting based on some criteria. The periodic occurrence of laryngeal obstruction is another way of looking at this. We don't talk as much about supraglottic collapse or collapse above the vocal folds in adults. We probably should. In children, it's very common, right, to have supraglottic obstruction. And so when folks talk about surgery for exertional dyspnea, they're often talking about supraglottoplasty, and they're often talking mostly about children or adolescents. And so that's what this arm is all about. So it's another way of looking at it. And I find these helpful because I think it allows us to have more specific conversations about sort of what model are we working from and how are they all together. So this is not a great slide for projection, but I think it's a great slide for thinking, which is what is our process for thinking through what these things are, right? So is this based on triggers? Is it based on activity? Is it based on sight? Is it based on certain historical factors? Is it based on whether they just sound noisy or they feel dyspnea, right? So what is our map of the condition? I think it's useful to have that. So I like this paper because I think it clarifies the current understanding of thinking. Any questions before I move on to some assessments and some videos? I don't know if they are allowed to text me, or I don't know if anyone had any questions so far. Okay. Do you have any questions? We have 3 speech-language pathologists who are in clinic every day that I'm in clinic. So we have Lindsay, Kayla, and Maxine who have joined us. So howdy, partners. And so please feel free to chime in. So this is our assessment roadmap in 2015, right? It starts with historical factors, really focuses on triggers, and focuses on laryngoscopic findings. So when we do a scope, what are we looking for? I'll show you that in 2017, this is out of the more recent paper, really thinking about what are all the symptoms people have? What is our best understanding based on the laryngoscopy that we're performing, where they're located, and then really thinking about all the possible triggers that are there. So casting the net more widely without trying to lump toward a specific consideration. So it's changing. The best thing about working with the group at the Lung Center is that I never have to question this diagnosis. Like if you all say that they have asthma or they don't have asthma, I believe you. It's beautiful. It's wonderful. So many of my colleagues across the country and within the region don't have that kind of a collaboration. So if there's any question about any outside testing, I trust this group here so very much, and I really appreciate that. So I know that we're there. The other piece is that often patients have both, right? So in studies, right, 50% of patients with paradoxical vocal fold motion have asthma. I'm not sure how rich that data is. I think there's some correlation, certainly, between having more than one thing. So if we don't make sure that we know what their status is with regard to their asthma, treatment for paradoxical vocal fold motion probably doesn't work for asthma, right? So making sure that we cast the net widely enough and that we're not leaving something out clinically for our patients. So because we can really trust the diagnosis of asthma, and we're often referred patients from our allergy colleagues or our pulmonary colleagues, we're not really differentiating so much of whether they have asthma or not, like what else in the upper airway. So our history is actually usually very focused on that. And for patients that have both asthma and something else, we really kind of ask them about what their experience of breathing is like when they have asthma, and how is that different from whatever else is happening. Just again, really kind of concentrating on airway symptoms, any noise, and you have to have enough airflow to have noise, right? So some patients who are having a concomitant asthma exacerbation and they're not moving as much air, right? So it's helpful. For triggers, again, we just make sure that everything is optimized. So here is an office assessment. And this is one of our first office assessments. And I'll show you what we noticed. So I didn't edit the videos because I think it gives you a really good idea of what we sort of look for, right? We're looking through the nose, and patients can often have more than one thing, which I think will hopefully be a good take-home point too. This patient was actually a premature infant by history. She's now in her 30s. She has some congenital subglottic and infrachordal narrowing, right? She also has asthma, diagnosed by one of you all, so I really trust the diagnosis of asthma. And I met her in the operating room because they had called for assistance and an intubation. They were unable to pass a 7.0 endotracheal tube for an emergency hernia surgery. So I happened to be downstairs. Anesthesia came to get me, and able to intubate her with I think she had a 6.0 tube, and she woke up with stridor and had a similar appearance of larynx, right? So we see her, in follow-up. I'm really her asthma has been really poorly controlled. Her first language is also not English.
And say hee 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 hee. Ah woo. Ah woo.
So we're looking at how her larynx functions.
Una, dos, tres, cuatro, cinco, seis.
What your ear hears is that she runs out of air when she's counting.
Nueve,
you can hear it.
Great. And hold out.
So her breathing and her talking are not well coordinated. You can hear the pitch drop and her voice get rough when she runs out of air. That's why we care about the voice. It's a tell for the coordination of the breathing, right?
Beautiful.
You're going to see her larynx close. It's incredible how many times we actually see the larynx closing during exam, and sometimes the patients, they're not holding their breath. Their larynx will just kind of close when they're going about their usual business. It's fascinating.
Good. Now put your chin up in the air.
There we go. That's it.
And then lower it.
So she's not symptomatic. She's not holding her breath at that point. Her larynx just closes when she's run out of air. So that could be considered a paradoxical phenomenon, right? Now, when I first started here, I hope that Elliot and Chris, you will hear this at some point. It was very humbling. I thought I would just come in and start seeing patients with a speech pathologist and tell everybody to breathe in through their nose and out through their mouth, and everything would be perfectly fine. So I got a page from Dr. Israel one day, and he's like, Jayme, the patients are like not getting better, and they're like really not sure what to do about this whole breathing thing. I was like, oh, we've got to figure this out. Thank you so much for the call. So what we did is we started actually looking at what's happening with the larynx with the camera in, because we could. So a lot of the respiratory retraining exercises were done from the outside. But that cue of breathing in through the nose and out through the mouth doesn't do the same thing for every patient. And it turns out there's a ton of different things that you could ask people to do. So I really appreciate the feedback when things aren't working, because it changes the framework for how we sort of figure out what's good. And then I would only say this, is that we think we've got a good idea of what's happening with someone when they're in the office chair, but we're also not there when they're doing whatever it is. So maybe we've given them something that might work in a chair with a scope in their nose, but maybe that also might not be the thing that they need, right? So really just understanding and really deconstructing what you have. So this is laryngoscopy during spirometry. So we had a patient bring
And sniff, sniff. Good.
bring a tube to blow through during the exam. So you'll see what happens with the larynx, right? So this is
and take a deep breath in.
just her breathing.
So now I'm going to have you lower your chin a little bit more, and I think I'm out of your way enough. Does that feel like I'm out of your way more? Okay. Now take a deep breath in and do a really nice, huge forced exhalation.
With the thing on my mouth?
Yep, with the thing in your mouth.
So she's putting the thing in her mouth and doing a forced exhalation. You'll see what happens to her larynx. So
okay. Good.
So her vocal folds are closing.
And forced exhalation. Okay, now take it out.
Right, so normative data of what happens to your larynx during flow volume loops are not readily available. And in
Okay, now breathe in.
observing in the
Good.
pulmonary
Do you
function
feel like
test
any shortness of
lab
breath at all at any point during that? Like, do you
here
feel like you're trapped,
and during
trapped with air? Or?
dynamic airway testing,
Oh,
the
really?
positioning that patients
So
are
now I want
in,
you to say, "Hey,"
how much
really
they're
loud.
breathing.
Hey.
See your larynx closing?
Okay, good. I'll show.
That's just
actually
her
really cool.
sitting
I'll
there.
show you. Sniffing. Good. Now, hey, hey.
She's
Okay.
asymptomatic
Now, really
when
big
her
forced exhalation.
larynx closes for a second, but we don't think it's breath holding, right? Because if you hold your breath, things should close.
Sniffing. Okay, good. And now with that thing.
So these are things that we observe on the test, and I think are really, really helpful in terms of generating hypotheses, right? I'm not sure exactly what the correlation is between symptomatology, right? So we know when we hold our breath, our larynx closes. When we run out of air, for whatever reason, the vocal folds tend to shut. So I'm not sure how exactly that is demonstrated on your flow volume loop. Fascinating. So again, we get a good sense of what's going on with the sinonasal mucosa, what's going on with the pharynx. Can see cobblestoning really easily here. It's not that pronounced in this patient. This patient had exertional dyspnea, and you'll see him later on a treadmill. So for our clinic, we like to meet the patients before we ask them to do something that might make them feel unsafe, right? So if you have a problem where you feel like you can't breathe, and then we ask you to reproduce it, we want them to like know us. We want them to have experienced a laryngoscope in their nose first. We want them to know how to best convert their breathing to laminar flow with a breathing technique that works for them. Because if we're going to ask them to push their limits, we want to get something out of it, even if it's knowing that our treatment is effective, right? They may not get a good answer for what the diagnosis is, but we feel that for provocative testing, we're most comfortable having met the patients first and having some kind of a relationship with them before we ask them to face their obstacle. So this that laryngeal examination was not very remarkable, just in terms of the anything closing with the larynx, but there was a lot of tension in the larynx, and that's a finding that we're able to see on the laryngoscopy. So the supraglottic tissues are squeezing above the level of the vocal folds. This is what you would see in the up-to-date article, that when the larynx closes, that there's this posterior chink. If anyone's ever been interested in what that means, it's just a space in the posterior aspect of the larynx, which you can see sometimes, but you can't see other times. So this is kind of the stuff that was usually on the board exam that we're sort of moving away from, because we think it's probably a bit more of a dynamic phenomenon or process or a series of findings than one thing. But it's hard to sometimes find pictures of that sort of posterior chink. So there you go. So we're really talking about clinical phenomenon rather than maybe one specific entity or a strictly defined clinical diagnosis, which may drive a lot of you crazy. It is hard, right? And it also drives patients crazy because they want to know that I have something and what it is and what it's caused by. We're just not there yet. And it can be coincident with a lot of other conditions or other upper airway phenomenon. So I'll show you in a second. Someone who has unilateral vocal fold paralysis who also has this, also has a laryngeal airway obstruction. There's another office assessment, right? So this is a dry, crusted nose. This patient would describe herself as a mouth breather. So we really get a sense for thinking, if we limit our assessments as clinicians from just the larynx, we're probably missing it, right? So the air has to come through the nose and the mouth to get into the larynx, right? So if we see a nose that is crusted with hypertrophic turbinates and the patient's mostly a mouth breather, that impacts their sensation of breathing, and that can also be addressed, right? So really kind of thinking of the whole clinical picture and the whole patient. And so if you just kind of pass the larynx through the nose without looking, right? So you miss all this irritation, matted mucus. You can often see mucus in the nasopharynx.
until if our nose
So again, you know, just kind of thinking of how we learn anatomy. If I edited all these videos for you, it doesn't have you think about the unified airway as we think about the patients. And if I just focus on the larynx in this patient, I miss her fungal colonization. So you're going to see white spots here, 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 here. So this is fungal laryngitis, right? So it's not in her endolarynx. It's not seen in her mouth. But this is someone who's mouth breathing, who has a fungal colonization that may be changing the viscosity of her, or efficacy of her mucus blanket. This is changing her physiology somehow. We often find that when we treat patients for fungus, then their airway reactivity decreases from an upper airway standpoint. So again, just making sure to have a system for casting the net widely. We have lights that make it easier for us to see this, like kind of like your narrowband imaging, maybe with your Olympus system. We have a Pentax system. You can more easily see the fungus. So we're going to try some airway exercises. She may look really familiar to you all. Yes, exactly. So I just took some recent examples. I mean, we see this all the time, every day that we're in clinic. So I figured some more recent examples might be helpful. So what this shows is we're trying to figure out which breathing strategies work the best for her. And what we look for is to see if the larynx remains open. So we look at the vocal folds; they stay wide on inhalation and exhalation, right?
Can you yawn for me?
So, and then we're trying to get her pharynx open. We're asking her to yawn to stretch the pharyngeal muscles. So by and large, we're able to figure out a breathing pattern that works for her. So now I'm going to move to exercise. Unless do you all have any other thoughts about office assessment for breathing work? No? Okay, but I would encourage you to ask them questions while they're here. So during exercise, we have a setup that allows us to put this camera, which is like a CMAC, like what you'd intubate with in the operating room. We have a flexible laryngoscope, so it doesn't have sound recording, but it does allow us to record. And because it's a larger scope, we don't actually hook this up to a helmet to have people have continuous laryngoscopy. So we do laryngoscopy at peak exertion, which I think has problems. But this is sort of the idea, is that someone's on a bike or a treadmill, and you can hold the scope there, but you definitely know that your cardiopulmonary exercise testing data during that, you have a system that's going to leak. So you're not doing a comprehensive study for how the heart and the lungs are really interacting. You're just looking at the larynx. So here is a patient who has had exertional dyspnea and stridor for 9 years. And she had the courage to undergo exercise testing. So she had a full level 1 CPET. And during peak exertion, she felt like she couldn't go anymore because her knees couldn't pedal the bike anymore. So I'll show you what her larynx looked like at peak exertion. So this just tells you also, so the record is on. So there's a time interval from when the patient is getting off the treadmill or getting off the bike and between when we're sticking that in. We're missing stuff during the time interval, right? Whatever is happening. I mean, it's a significant time interval. That said, they've worked so hard during this test that usually there's some residual adenoid pad. By the time that we're in there, we can see, I'm sorry. I think I gave you the regular, this is the regular version first, sorry. So this is a patient without an abnormality in exercise. So you can tell the larynx is moving. I'll stop clicking in just a second. I'll figure this out. Sorry, guys. All right, here we go. So you can tell that the larynx is fully abducted. There's a throat clear there. When I press pause, it switches to the next one, sorry. So there's a throat clear there. The larynx is open during exercise, and you can see the larynx moving up and down. So this is a pretty typical experience of a larynx being open after exercise. It's a very typical experience. Within that, you see some throat clearing where they're like, there's no sound. So you can't tell if the larynx is just closing or if they mean to do it. So that's what some of the challenges are with our current testing environment. So this is the patient I was talking about with unilateral vocal folds. Or is it? Maybe someone else. All right, here's, sorry, I forgot what order I put these in. So this is someone who has an irritated larynx who we put under CPET testing. It looks like just a beefy red irritated larynx. A lot of throat clearing during this. So what we'll do is we'll actually, when we put people through this testing, we'll remark about how much throat clearing they have and what other things do we think that just might help their experience of breathing during exercise, right? So are they dry? Do we see sometimes frank reflux coming up from the esophagus? What else can help the patient? Here's the patient I spoke about, sorry, with the unilateral vocal folds. So this patient didn't. Sorry, I'm just gonna let this play so I don't. So you'll see that the left vocal fold is immobile and the right vocal fold is mobile. So this is what a unilateral vocal fold immobility looks like with exertion. So her airway is half the size of the person that we saw last time. So sometimes just having a static laryngeal problem, because you're moving more air, it's symptomatic, right? So in runners, they feel a unilateral vocal fold immobility. I had thyroid surgery. My vocal cord doesn't work now. I feel like I hit a wall when I run. I could tell you that in the hospital, patients aren't told about their exercise symptoms with unilateral vocal fold immobility because most people don't report exertional symptoms because they are more focused with talking and swallowing. But if you move enough air, your larynx needs to be wide open when you're exercising, and for athletes, they will feel that. So we've had a number of people come in for CPET testing where their vocal fold dysfunction is the unilateral vocal folds not working. So their larynx isn't closing, their larynx is just half the size it was, and they can feel it because they're their airway needs to be wider than their demands. So this patient was very upset because she's seen 9 people. And I can tell her, listen, it's your vocal cord that doesn't work. And she's like, no, there's something else that happens. There's this other thing. And she was so upset that actually she had an episode of her larynx closing, which you'll see. So I put the scope back in because she was afraid that we missed it. You know, she couldn't pedal fat quite enough to kind of reproduce it. And we were talking, and she was so upset that we didn't catch it that it happened. So she's trying to use rescue breathing to open her larynx there. So that's her larynx is staying closed, right? So that is an episode of exercise-induced laryngeal obstruction in a patient with a pre-existing unilateral vocal fold paralysis. Fascinating. So I like this video a lot. This is the gold standard now. This is, you see the helmet? So you put a tiny little pediatric laryngoscope there. Now what's really nice is when this is actually synced with your CPET software, which you can do. So you can sync the sound and you can sync the images so you know what's happening with the heart and the lungs and the larynx. They usually have to wear a nose plug. There's other gear that's missing in that video for the setup, which you'll see in another video. So people have tried to really, because there's recording for continuous laryngoscopy, have tried to define that for quite some time, for over 10 years. And there's not still great consensus, but there's a lot of thought. And I think the work has been great thus far. And also patients who have a noise when their larynx is wide open. Right? So we can look and we hear the patient's noise and we see things are open. So where is the noise coming from? There has to be a constriction somewhere. And there's often noise and constriction with a sensation of difficulty breathing, but not always, right? So really trying to correlate all of that. That's been really fascinating for us. And we do see a number of patients with lower airway disease of some kind with pharyngeal constriction. We're not sure why that is. So pharyngeal stridor, it's a little bit different. And we do see the pharyngeal narrowing, and we do hear a characteristic sound that is coming from the pharynx. They're right. this is a nice piece. I think.
Training for triathlons is more than just a hobby for Tyler Evans. It's his job. So when Tyler started having serious breathing problems, he stood to lose more than just a few races. His livelihood was at stake.
I thought, my career might be over at one point. I might not be able to keep doing this. What if there's something not just career ending, but, something that's life threatening? There's a lot of things that were going on in my head.
After seeing numerous doctors for everything from heart problems to asthma, Tyler went to National Jewish Health in Denver, where doctors diagnosed him with vocal cord dysfunction, or VCD. At certain times during exercise, Tyler's vocal cords began to close, which not only made it harder to breathe.
It often is just terrifying. So independent of the effort required to breathe, there's this emotional effect.
Unable to manage VCD with medicine, many patients turn to surgery. But Dr. Todd Olin is taking a different
what surgery
approach.
Are they talking
he puts
about?
athletes on an exercise bike and puts a camera in their throat. He then uses biofeedback, specialized breathing techniques, even speech therapists and psychologists to treat patients, not just in counseling sessions, but in the midst of strenuous exercise.
I work with patients while they're pedaling as fast as they can on a bike or while they're running at 14 miles an hour on our treadmills, so that they can learn.
75% of adolescent athletes.
So anyway, it works. So I am happy to send this list. This is the curated work within 2017 that I think is actually really useful for non-exercise and exercise laryngeal obstruction or upper airway obstruction of some kind. I think it's there's just an exploding amount of their diagnostic classification and treatment options it's an exciting time to be able to serve this patient population. So the challenges with this are we're really studying phenomenon on a continuum rather than a specific condition. And there's a lot of blurring between the diagnosis and treatment, right? So if we meet people before they go on a treadmill, like maybe we've actually taught them something that's helpful, or maybe they have so much jaw tension that the mouthpiece that they use during the CPET testing changes the area of their throat and they are better. And that we've had that happen. They're like, actually, like we can run longer. So we learn from each of these, right? I run longer on this treadmill, not because I'm running slower or I'm working less, but like I'm better. Like, oh, okay, great. So maybe sometimes just not having a historical diagnosis rather than a actual diagnosis, it may serve the patient. So there's blurring between the diagnosis and treatment. So that can really lead to a lot of mess when we try to study these types of conditions too. And vocal cord dysfunction is now kind of considered sort of like a wastebasket diagnosis because there's probably kind of a better framework for it. But I'm sure there'll be another term the next time that we talk together. And I just wanted to leave a couple of ideas for future directions. We just had a Women's Lung Health CME conference last Friday, and there's so many gender differences. So I think sex differences in the biology, it's not just the airways are smaller in women, right? The airway dynamics are different. We see that in the voice box. We see that for a number of different disease processes. So there's probably real biology here that unfortunately we're probably biased not to look at. Right? We need to improve the criteria for testing, right? What's our pre-test probability for what we're going to get out? Does that serve the patient? Is it academic curiosity? Do we need to do the work to figure out what it is that we're treating or all of what we're treating? And then consensus on interpretation of testing, right? Just like with the pH probe, if you ask a certain question, you'll get a certain answer. Maybe we're not casting the nets wide enough. Maybe this is an opportunity for machine learning with some of the history for some of these things, right? So maybe there are symptom complexes that are really obvious to people who are really good with pattern recognition. So I think there's so many opportunities. And I think that the biggest blessing about being part of the Lung Center is really the opportunity to sit down regularly with many of you to really kind of think about how we think of this as a unified airway process. So we'll leave that open for questions.
Hello? Hold on 1 second. Can I have the microphone, the handheld mic? Oh, there we go. Thank you very much. Jayme, that was wonderful. Really well done. And I learned some anatomy as well as physiology and pathology. It's fantastic.
Thanks.
And there was quite a bit of data. So thank you very much for that. I just want to ask the first question, and I also want to remind people to please text 617-759-2424 if you have a question and you're watching on the web. So the first thing I would just ask you is, so we can be up to date with the parlance of the trade in the day, are we asking for a noisy breathing evaluation? Are we asking for a episodic laryngeal breathing disorder evaluation? How would you like us to ask for help when, as clinicians, we feel we need your help?
I think it would probably be best to stick with like upper airway symptoms or upper airway evaluation of some kind. I think it's vague enough, but it's also accessible to the patient. And if you Google upper airway, the stuff that comes up is like teaching people about their nose and their throat, which seems good. So I don't know. That would be just I'm throwing that out there, but I don't have any data behind that suggestion at all.
So we do have a question from the web. I'll start there, and then we'll ask folks in the audience if they have questions. Okay, and this comes to us from New Hampshire, and thank you. Oh, actually, it's quite a long question. Okay. All right, so this is from a community-based pulmonologist. Superb talk, Dr. Dowdall. Really, really exciting that this is gaining more acknowledgement and traction. In the community setting, the diagnosis of asthma unfortunately can frequently not be trusted. At the same time, many community ENT colleagues tell patients that I refer that they don't have anything wrong, yet we know that it's so hard to catch it in the office. Can a diagnosis of ILO be made clinically without the much quoted gold standard of direct visualization of abnormal movement? The prevalence in the community is huge, all caps. The knowledge about it is spotty at best. Thank you very much.
Thanks for your question. I actually, I think it's in that setting, I think you're most likely to miss a diagnosis of exercise-induced asthma, right? So, I think as otolaryngologists, we need to really understand, what our diagnostic capabilities are and when we should be referring to our allergy and pulmonary colleagues to really make sure that we're catching exercise-induced asthma, right? And then for the laryngeal components, a lot of it is still based by history, and so I do think that depending on the patient's case, it either is or isn't required, but it is on a case-by-case basis based on the patient's symptomatology and reproducibility. So sorry to give you a slightly wishy-washy answer.
Can you hold on just a second? It's on the web, they can't hear you.
So this is Lindsay. I'm just the speech pathologist perspective. It is so helpful to see a person's larynx when we're talking about this, because there are so many times when we think we know what's going on and we get in there and we look and we're like, wow. Okay.
So it's a really important point of clarification. They should always have a laryngoscopy, but I don't always think that they need to have an exercise-induced test. Part of it's like if you have a swimmer, it's tough, right? To kind of it's possible, but I mean that's kind of where's the carryover from the testing environment to the person.
I think that's a basic, is to say that we want a laryngeal exam just to
Absolutely.
be able to see what's going on, even if it's just at rest. There's just so many behaviors and patterns, and even some of the people we saw this morning, it's just some things just look funky, or some things are just kind of behaviors of the larynx, and maybe that influences the way that somebody is then exercising or doing activity. So it is helpful.
And you're not just a speech pathologist, you are like the mainstay of diagnosis and treatment for this disorder. So I'm so honored to have you as colleagues. Yes.
Thank you, Jayme, for the excellent talk. So 2 questions. First, if you can comment quickly on your interest, what you're working on, the peak flow measurements in this setting, And second, what we can do to make the test that's currently available better. I heard that you have several concerns about that. In addition to the fact that the laryngoscope is not stable in terms how far to go, how like to reach the symptoms or peak exercise. So what can we do together to make this test more reliable?
So I think it would be really helpful to actually have a period of observation where we actually look at the person and the technician as they're doing the either spiro or pulmonary function test. It is enlightening. It's just very different. So the coaching can be the same, the patient's height, the chair. So just actually having a multidisciplinary observation of sort of what's happening during the test, I find that very enriching, and I think has, it really has impact on the testing, right? And then also trying to instead of the nose plug, putting a plug in one nostril and putting a scope through a plug on the other side, seeing what the normative values are for laryngoscopy during pulmonary function testing. We don't have that data. Right, so they've concentrated mostly on exercise, but what about just regular normative data for age and gender? So it would be helpful, I think, to do that. And I think lastly, it would be great if we could move to an environment with continuous laryngoscopy and sync that with our CPET. We just need a helmet, a pediatric laryngoscope, and a little bit of programming just to link the software with the timestamp. And I think that would be great for us. Yeah. No. So if you have any ideas for funding mechanisms, I am all ears. I will. Yes. We have not done that study, and I would love to do that. So if y'all would be interested in partnering, I would love that. And I think dry air is going to be really interesting, right? So and then UCAP neck. Yes. Yes.
Jayme, I really learned something here. Thank you. It was a beautiful talk. Do you think that the relative length of the extrathoracic trachea could play into the sex differences?
Yeah, absolutely. Yeah, the female larynx is also right up near the base of the tongue too. I mean, it may be a function of the length of this, or it also may be a function of the larynx being high. There's something in addition to the anatomy also that's probably at play high.
So quick, we'll have one.
Two super quick questions. One is, when you referred people, right, some from allergy, some who have known upper airway stuff, or some who have known reflux.
Yes.
Reflux. Are there clinical observations you would care to comment on about what their airway looks like that differentiates those groups? For instance, one thing I think about in asthma, one of the changes in airway remodeling that we talk about less is vasodilatation, but there's actually really nice pictures on bronchoscopy that you can see with this really dilated vessels lining the airway, including a little bit of the upper airway, right, in people who have mild asthma, severe asthma, asthma on steroids, asthma not on steroids, which really differentiates it from even things like COPD, at least in the literature. I haven't looked at this carefully myself, but and I'm wondering whether you ever look down people's airway and go, oh yeah, I mean, that's clearly going to be an upper airway allergic patient, or are there certain sine qua nons of?
Yes. So the problem is we've been taught the redness or hyperemia or vasodilation was reflux, and our scopes weren't that good. The bronchoscopes were better, right? So now that we have better equipment, we can actually see the new. It's not just erythema; it's actually the blood vessel. We're able to see that phenotype, right? And you have to deconstruct what you were taught, and it turns out you can't make the diagnosis of reflux with your eyes, like we were taught. So yes, and I think there's just not been data on that. I think probably because of our sort of journey to get there from here. I would love to start one. That sounds like our next homework. It'll be great.
Well, that's a wonderful concrete step forward. So remotely, as well as in the audience, if you'll join me in thanking Jayme for all of the wonderful information she's imparted today.
Thank you.
And special field additional questions if you want to come on down. Thank you. Have a great day.
Thanks so much.
Thanksgiving.